Paul Ginsberg at the outset mentioned some work I've done in the area, and I just want to take a moment to bring that into the discussion. First of all, at Health Affairs, where I'm the editor-in-chief, just in October we had an article on trends in inpatient and emergency department use associated with opioids, very important information for addressing the issue. We've had a number of papers on the effectiveness of prescription drug monitoring programs, which is a topic that comes up fairly often. We have very powerful Narrative Matters, which is a first-person narrative of a person who was trying to get themselves off of opioids in a healthcare environment that didn't actually seem particularly interested in helping them with that. So I hope you'll look to some of the work in Health Affairs on this topic. In addition, Paul is a member of the Aspen Health Strategy Group, where I am the director. The Aspen Health Strategy Group is only 2 years old. It's a program of the Aspen Institute. It brings together CEOs of a broad range of organizations, Aetna, the Robert Wood Johnson Foundation, Premier, the National Academy of Medicine, Epic, Merck, Marriott, Consumer Reports, and the like. And each year the group takes on an issue. It's chaired by 2 former HHS secretaries and governors, Kathleen Sebelius and Tommy Thompson. Our second year, which was the year that is coming to a close, the topic was the opioid epidemic, and the group spent a few days discussing it with background papers prepared by experts in June. And the groups were in the final process of finalizing the report, but it's framed around some findings that I think will be familiar if you've been here this morning, and some recommendations as well. The complex origins of the crisis, as we definitely heard a lot about this morning, the multiple roles of the healthcare system in creating and addressing the crisis, the significant gap in treatment availability, and the significant gaps in our knowledge about the nature of the crisis, as well as the need to find partial successes and learn from them and spread them. And that led the group to propose suggestions in 5 areas. The first around overprescription. Again, you saw the data just moments ago about how we're a global outlier and the need to bring rates of prescribing down. The need to treat addiction as a public health issue. This doesn't mean there is no role for the criminal justice system, but it does mean that addressing the problem has to primarily be viewed through the lens of public health. The imperative of stopping the deaths. Overdose is reversible. That doesn't solve the problem long term, but it does prevent deaths and create an opportunity for treatment. The importance of guaranteeing access to treatment, where we have a tremendous gap in availability. And finally, to increase our investment in data and knowledge so that we can improve treatment of pain as well as treatment of addiction itself. So this is a report that will come out from the Aspen Health Strategy Group later this year. With that, what I'm going to do is I'm going to ask our 2 new panelists who work in this area to describe just briefly what their work is, and to give a little context to some issues that haven't been brought up as much in the morning sessions, and then I'll ask some questions of the panel and we'll open it up to you. Let's go ahead and start with you, Jason.
Great, thank you. Well, my work is in the area of physician decision-making and encouraging better prescribing. A lot of what we've been talking about today fits in with that, and I think some of the comments by Sir Deaton and also Dr. Madras relate to this type of work. So, you know, some of the big issues are around the fact that something Dr. Madras brought up, clinicians are good at learning clinical facts, but to be an expert in decision-making is an entirely different thing. And what we've seen is that there's been this breakdown there with regard to opioid prescribing, and how do we address that? One way to address that is through reversing the social pressure that was brought on to increase prescribing by, you know, having doctors be more accountable for their prescribing, and also to know what their peers are doing, and to understand who are the top performers and who are the top performing physicians in their practice, and to incentivize prescribing that is safe and effective rather than perhaps unsafe. That's going to require data. It's also going to require closing the loop on deaths, what I call closing the loop on death, which is that doctors don't understand or they don't know, they don't learn of when their patients die because we have a fragmented healthcare system. And so these large clinical data networks and databases, PDMPs, this data needs to come together along with medical examiner data so that doctors can understand what are the effects of the prescribing that they're doing, and also, as they scale back on prescribing, what are the effects on illicit drug deaths as well. The third thing that I'm interested in is non-pharmacologic treatments for pain. These were actually quite common up until the mid-90s. They sort of fell away. Partly that was economic. The economic model behind them wasn't very sustainable. But there's been a lot of work since then on those treatments, and there's ways to deliver them that are much more cost-effective. And physicians need training in that, and we need a infrastructure for supporting that, and also reimbursement for those treatments. So those are kind of the issues that I'm interested in working on around the crisis. I agree with the committee's recommendations and report that this crisis is not easily characterized medically. It's not easily characterized legally. We have to think outside the box, bring together new ways of addressing the problem that will tighten the hold on opioids so that we can reduce exposures, because that is what's driving new addiction and dependence on these drugs.
Thank you. And Rebecca?
Oh, there we go. Thank you. Thank you so much for the opportunity to participate in this panel and for the excellent comments that you've heard thus far. I'd like to emphasize 3 policy recommendations based upon my work, which is as a lawyer and a health policy researcher around kind of wise policy responses at the state and the federal level to this epidemic. So first, as a matter of procedure, the imperative that we distinguish public health emergency actions from those that are non-emergency. Second, the need to nationalize policy, in my opinion, around prescription drug monitoring programs, something that I study closely. And third, key mechanisms to increase the provision of effective opioid use disorder treatments. I'll focus my comments on buprenorphine. So first, in terms of recommendations, we've had a lot now, 56 from the Commission. We've had a National Academies of Sciences report. We heard President Trump's comments last week. And so the question is sort of, all of these things are important. Where do we start? And given the public health emergency declaration a week ago, and to make this more than just a symbolic act, we need to think about what the best use of those powers are. And really that's for acute, imminent public health threats. What can we do in the 90 days of this order to really make a dent in my mind, mainly these opioid overdose deaths, 91 happening every day. So we need to be thinking about allocating money and funds in the Public Health Emergency Fund, which currently has almost empty, and having Congress appropriate money towards that, and think about particularly increasing naloxone and medication-assisted treatment therapies, using that money, increasing the provision of that at the state level, and naloxone to EMTs, to other community workers, to prisons, and potentially friends and family. So we can really make a dent in that particular outcome in the very short term. And then think about kind of many of these other recommendations over the longer term that are more structural. And that money that's going to need to be appropriated, I mean, is in the order of, even just for the public health emergency, in my mind, in the billions. Second, the federal government, I think, has an increasing role to play in prescription drug monitoring programs, or PDMPs. These are state-based databases that aggregate controlled substance prescribing. They're very rich databases. They've been around for a while, and 49 states have them. From a policy perspective, they're very heterogeneous, and we've now kind of tested a number of different features in the laboratories of the states. And the federal government has been funding a lot of this. And currently, there's the PDMP Act of Prescription Drug Monitoring Act of 2017 proposed in the Senate, I think that gets us partway there to nationalizing some standardized metrics and features of the program. It would condition funds of PDMPs on data sharing at a federal DOJ hub, and also daily updates of the data. But I think we can go further because we know other mechanisms that are effective with these programs. The Commission did recommend mandating use of the systems. I think also mandating registration for controlled substance prescribers, allowing delegate access, integrating the data into EHRs, actually using these databases as referral centers, so being able to search and find treatment providers in your locality using the databases. These are all best practices, many of which are very evidence-based at this point, and there's, the federal government has a role to step in and really standardize these systems. Finally, and increasing the access to medication-assisted treatment therapy, or MAT, in my mind is an imperative. The treatment gap is substantial. We have almost about 3 million people with opioid use disorders. By best estimates, we think like less than a million of those are getting treatment, or some people say 25%. And of those, some are not even getting the evidence-based treatment. So medication-assisted treatment therapy, it does actually have quite a strong evidence base. I agree with Sir Deaton that we haven't been able to test some of the other alternatives, but we do know that these medications, especially when supplemented with behavioral health counseling and other support services, are quite effective. Buprenorphine in particular, I think, has great potential, and maybe naltrexone, although the evidence base isn't quite as strong for that drug yet, because they can be provided in primary care settings, and we can get that access from a primary care provider and not having to go to addiction specialists, of which there is a dearth of supply also. So things to be thinking about, some of which the Commission recommended, but some of which they didn't, include eliminating the waiver process for buprenorphine prescribing, and instead training more broadly in medical school and CME education. Reimbursing better for counseling and support services, so we're getting the full panoply of support services here, and reducing the costs, especially if some of these drugs are very expensive, and the federal government could play a role there, so that insurers can cover them robustly and prescribers can choose which therapy is best for their patient. And finally, things like loan forgiveness and other financial incentives for providers to actually get out into those areas, those rural and underserved areas where there just aren't actually providers providing these services. So, because as much as we can reduce stigma and get patients to try to access these services, and those are all very important, if there aren't providers to actually provide these services, which right now there is a dearth of supply, then we're not going to get very far. Thank you.
Great. I'm going to start with a couple of questions to the panelists here. I want to set aside the broader economic structure of the American economy, which is probably a little more than we can take on. I did promise we wouldn't talk tax policy this morning. And setting aside even the question of how many dollars need to be added to responding to this problem, I'd like to try to get a sense of how much consensus we have. It's been commented repeatedly that we're having more conversations. It's moved up on the agenda. Those are all true. But is there really consensus? Where do we have consensus about either the nature of the problem or the response to the problem? Where is there still significant disagreement? Who wants to take that on?
I think there is very strong consensus on increasing access to treatment, increasing access to rescue, increasing health care insurers' responsibility in this because they have an enormous impact. They approved prescription opioids indiscriminately, yet they put roadblocks in terms of approval for medications-assisted treatment, and they put roadblocks in approval for treatment itself. I would say that almost every one of the recommendations you have is in our report in terms of the entire spectrum. What is controversial, I think, and which most people who have these, what I call facile solutions, because they're almost chapter headings, is once you start to think about reducing to practice, it's far more complicated. Educate physicians. will they listen? How do you get medical schools, 125 or so, to incorporate pain management, opioid prescribing, and addictions recognition and treatment into the curriculum? I've tried for 20 years on this one. There are so many issues that have resistance to change from many sectors of our society, and the buy-in can easily be accorded to the federal government, because the federal government has regulatory, legal, statutory oversight, and also finances. But getting people to be interested, physicians to be interested in taking care of people who have an opioid use disorder is difficult. You can give them waivers for buprenorphine, you can teach them how to administer, and yet the number who have waivers and who actually have patients who are eligible is a fraction. Recruiting people into this area is not that easy. So the answers are, the big topic headlines are quite facile, and they are logical, and there's tremendous buy-in from all sectors. Reduction to practice has another layer of analysis that is far more difficult, and the Commission tried to do that.
Anyone else want to take this on, Sir Angus?
Just very briefly, I mean, it's worth noting that these things are not prescribed in Europe by and large. I mean, in Britain, for instance, opioids are rarely prescribed outside of clinical, outside of hospitals, for instance. So, you know, if you had a hip replaced, they'll give you some when you're in the hospital, but you don't get any to take home. And we could move towards that. But I would point out that in Dr. Madras's own slides, you do see this drop. I mean, the doctors are in some sense getting a hold of this, so the prescription opioids are going down. And you really do worry about the heroin dealers and the fentanyl dealers who are standing outside the pain clinics waiting to take over the patients who've been told by their docs that they can't have that anymore. And, you know, that we can deal with to some extent because we've dealt with drug epidemics before, but that will not be particularly easy. Just to raise another perhaps red herring, I worry a lot about this term evidence-based, which always comes with a positive connotation, you know, because evidence-based is good, not evidence-based is not good. Evidence-based usually means a randomized controlled trial at best. Remember what a randomized controlled trial does. It tells you it works on average, right? So that more people benefit than are hurt. But it's quite consistent with very few people actually benefiting from a particular treatment. So, you know, we just need a richer structure. And remember, you know, the FDA is an evidence-based agency, and it approved OxyContin. And if you read the report in which they licensed it, they talk about it being safe because physicians know who's likely to be addicted and who's not likely to be addicted. I don't think physicians know any such thing. If I swallow OxyContin, I throw up. So I'm probably not going to get addicted from OxyContin. But apart from that, I don't think my physician has a clue as to whether I'm an addictive personality or not. So, you know, if the FDA is an evidence-based thing, it got this very, very badly wrong. And, you know, I presume there are recommendations in the report, which I haven't read. And the National Academy of Sciences said something about that too. But, I mean, the FDA did not come out of this covered with glory, nor did evidence-based procedures for approving pharmaceuticals.
The FDA is actually hit very hard in this report. And in one of the lessons learned, I can read it. I wrote it, so I should not have to read it. The approval process of medications with abuse liability should not be restricted to drug safety and efficacy in short-term clinical trials. It should expand its oversight and consider the number of doses, duration of a prescription, and the possibility of misuse, diversion, and tampering, and other consequences not traditionally a component of evidence required in the approval process.
Yeah, just on that point, I personally went back and read a lot of the FDA commentary from those meetings when they approved reformulations of OxyContin and when they approved OxyContin. And what was interesting to me was that the idea of the FDA for getting an expert panel together was to get people who had experience using opioids. And those generally were palliative care doctors and some pain doctors. And those doctors are using massive amounts of opioids at the end of life. And their patients are on death's door anyway. And so they don't really understand the notion of addiction or the notion of a life being shortened by addiction or the effect these drugs can have. And I think that is also part of the problem, that we should have people who've suffered addiction on those FDA panels. We should have addiction experts and extend who it is that approves these drugs, not just people who've had experience prescribing them.
Now, it does seem to me that the question of whether we view treatment as effective, Angus, I think I heard you say treatment's not very effective. We also have places where we don't have good evidence because we don't have the trials, and then you commented on the limitations even of those. The Congresswoman spoke about how we have very different expectations for other chronic conditions, and we don't sort of say, well, one try and you're out, or one failure and you're out. So I guess I'm curious, again, I'm always looking for where there's consensus, but also want to hear where there's disagreement. What do we really think about the effectiveness at this point? Is this a matter of shifting expectations to be more realistic, or are we very far away from even understanding what the right modalities of treatment are?
Well, I think that it's an excellent question. Number one is that this is a work in progress. We heard from insurance companies and from the Department of Labor on the difficulties of reimbursing because there are algorithms for treating almost every medical condition except for addiction. You know, for chemotherapy, there's so many rigorous standards that are being used and applied for most medical conditions. In this case, it's an open field day in terms of what goes. And I have been to many treatment centers in the country, some of which are excellent and others which are bizarre and so out of kilter with what we consider standard of care that it shocked me that the federal government would reimburse for this. So there is the American Society of Addiction Medicine, the American Academy of Addiction Psychiatrists. Both organizations are trying to develop a set of care standards that would be applicable across the board. The Commission clearly understands that this is a problem and also understands that treatment is not a one-size-fits-all for this condition compared to many others. If you have an infection, there's a standard way of dealing with it, or diabetes, or cardiovascular disease. With addiction, think about Lee Robbins' study of Vietnam War veterans, 20% of whom had returned from Vietnam with a heroin addiction. Of those, less than 5% remained addicted, and the vast majority never entered a treatment center. So there are clearly cultural, sociological, family factors that deal in. On the other hand, the other extreme, 80% of people who are addicted to opioids and who do not have medications-assisted treatment relapse very quickly. So we have very different populations with different genetic platforms that are, in fact, in need of help, and we have to understand how to tailor the help depending on the individual. At this point, we have certain principles of addiction treatment that I think are clear. It's a long-term chronic disease that requires continuum of care for the duration, just like diabetes. Medications-assisted treatment helps the vast majority of people. Other people don't want an agonist, a mu-opioid agonist. An antagonist may serve the purpose. There are so many considerations on an individual basis. There's certain subcultures that would be treated differently than others.
A tiny remark. I worry about statements like 80% of people who are in, medically supported. What was the term exactly? Medication-assisted treatment, because that's from the population who will go into that program. And so you've got a very large number of people who will not go into those programs. The Congresswoman talked about people not admitting they're addicted, and that's a huge problem in alcohol as well as in opioids. People just don't say they have a problem. And, there are very effective people who, run hedge funds while addicted to heroin. It's amazing what you can do. I also, we tried very hard to spend time at AA meetings finding out what goes on there. And it's clear that AA, even though it's impossible to study systematically, works for a lot of people who are in there, or they believe it works. And I see no particular reason to doubt that simply because it's impossible to do a randomized controlled trial. I think there's been a lot of difficulty with courts mandating people go to 12-step programs, which leads to all sorts of abuse. But, for people who believe in markets, most of those AA treatment centers or 12-step treatment centers are financing themselves out of money that people pay for the treatment.
I want to focus on the A and MAT, because we talk a lot about the M, the medication, but the assistance side, and I'm thinking, Jason, you talked about the non-pharmacological treatments, which is not exactly, which is a different kind of A, but gets at this question of sort of what's the non-medication side of this. Rebecca, you talked about treatment gaps. I just wonder if we could, it seems like there's a lot of attention to what are the drugs, what are their effects. What do we know about the non-medication element of the treatments?
Well, the study suggests that the medication-assisted treatment therapies on the treatment side, particularly buprenorphine and methadone, and I agree that those are short-term trials typically for specific populations, but quite in my reading of the literature, a strong evidence base for reductions in opioid overdoses, opioid use and misuse, spread of infectious diseases, many important outcomes. And it is quite strong as compared to other areas and levels of evidence we have in other areas of healthcare and health policy. I do agree we haven't been able to study as well. Generally, the study suggests that when we think of MAT, it actually includes not just the medication, but also the behavioral health therapies, which can include counseling and other forms of support. Generally, the evidence suggests that that adding those other components, the counseling, for example, is somewhat controversial, but the evidence says that maybe it does not increase the return of these therapies above what you would get with just the medications. That's what the evidence says. But I think we know that the best practices are to actually include those counseling, and we haven't been able to study the addition. I think enough the effects of adding on those other therapies on top of the medications, and also we don't know the effects of the medications and that combination of therapies over the longer term. So we really need to have better evidence generated in that regard. I agree. I think I just worry that I don't want us to go back to this philosophy that abstinence-only approaches are as effective as the medications, because the evidence does not say that.
I'm going to bring. I've got another question. I'll open it up to you all. We still have a good bit of time, but I want to ask about Sir Angus. You showed the racial ethnic breakdowns, and there is, I think, a broadly held belief that this is a rural problem, and you mentioned that what makes it unique is not that it's rural, but it's more equally rural than some others. There's also, I think, a lot of publicity around those who are newly addicted and affected by the crisis who are white. And I'm interested in how any of you think these beliefs, to the extent they are or aren't rooted in data, affect how we're responding to the crisis.
Well, we could get into a lot of trouble talking about that.
That's why I asked the question.
I know that, yeah, I mean, if you listen to politicians talking about the crack epidemic, white politicians, there's a famous speech that Ed Couch in New York talked about, which was, I have no sympathy for these people at all. They should be thrown in jail. If they've addicted themselves, they deserve everything that's coming to them. And that was the Democratic mayor of New York City talking about black people. And now you have Chris Christie, who's a sort of poster child for the way that even Republican politicians now talk about this epidemic, which is largely an epidemic of white people. And that has certainly not been lost on the African-American community, who are very sensitive to the differences in tone. Epidemic used to be a criminal disease when it was done by blacks. Sorry, it used to be criminal behavior when it was done by blacks. When it's done by whites, it's a disease. So, I mean, that's horrifying, and we have to live with that, and we have to sort of atone for that somehow. But it doesn't mean that the disease approach is incorrect. And I don't think that people, I haven't heard anyone who says, because of this history, that we can arrest our way out of this epidemic, that we can throw addicts in jail, and that will really fix things. So there is this disgraceful history behind us, and it's very hard from a sociological point of view. There's a famous old book by Courtauld, I think, called about the opioid history in America. What's his name? David Courtauld, yeah. And, I mean, he makes the point that, over 200 years, the treatment of opioid or opiate addiction, as it then was, has always depended on who it was who was consuming the drugs, even within, not necessarily across the racial and ethnic lines, but across socioeconomic lines, and whether it was men, whether it was women, and so on. So the history of American medicine has a lot to answer for in that regard. But the trouble is not the trouble, but I'm not sure how much that affects what we should do now. We should be behaving well now. And I think most of what people believe is that this is a disease, that addiction is a disease. It's a very difficult to treat disease, and it should be treated, not punished, and that punishing doesn't really help very much. That said, I mean, I think social sanctions against this can be very important. So that was why I emphasized at the very beginning of my talks, that communities knowing that this demon is out there and trying to stop it. The people, when a doctor gives you some OxyContin, he says, is that OxyContin? I'm not taking that. Think of some other way of treating me. So there's just a lot you can do by knowing about this and people knowing about this and shying away from this. Thank you.
Yeah, I was just going to say that on the prescribing side, and we know a lot of this from research published in your journal, that with regard to health disparities, there is a tendency to overtreat whites and a tendency to undertreat minorities. And this is an example of that. And it's possible, we don't know, but it's possible that there is implicit bias happening on the prescribing side, that doctors are more concerned about addiction with minorities, and not at all concerned with whites, and that could potentially have driven this high level of prescribing and willingness to become more liberal with opioids, given the pressures with the fifth vital sign and other factors. So just in general, to think about health disparities in that way, I think is useful because it does affect all sort of racial and ethnic groups in different ways, and this is one example of that.
Yes. There are a number of issues that I would just like to point out, and also ask Sir Deaton some questions, if I may. If you look at the NISDA data, the National Survey on Drug Use and Health, it is the largest database we have in terms of substance use disorders in the country. It surveys annually about 70,000 people. And in terms of the prevalence of opioid use disorders, it is highest among whites, 72%. And it's about 13% among Hispanics, 9% of African Americans. But overrepresented are 18 to 35-year-olds, 56%, males, 57%, low income, 67%, residents of large metropolitan areas, 50%. And about 40.1% have private insurance. So the demographics are quite, they're not simple. There's a lot of people in metropolitan areas. There are a lot of people who are non-whites that are using. But what I found so interesting in your data is the upsurge in deaths of people who were born from 1960 onward. And one of the factors, there are two factors that I really would love to interrogate with regard to that. Number one, that was the period in which chemical coping and chemical rewards became a national philosophical approach to life. Drug use surged in the 60s and 70s and has not abated really since that time. The only dramatic fall we saw was when Len Bias died in 1986, first pick for the Boston Celtics. Right after that, cocaine use just went straight down because he had one dose and he died. So the concept of chemical coping and chemical reward with regard to these demographics, I think, has to be interrogated. The second issue that I think is really interesting is doing longitudinal studies on individuals, starting from pre-adolescence all the way through into their 60s. George Valiant at Harvard has inherited a project that began in the 1940s, interrogating what happens to individuals throughout their lifespan, and using alcohol and depression and other cofactors. What he found is that in many cases, the use of drugs preceded unemployment, depression, and all these other consequences. So that some people have said, well, alcohol is used to cope. And what his data showed is that alcohol is the preconditioned factor that gives rise to a loss of employment, a loss of motivation, a loss of hope, depression, and all that. And I think that unless we have individual longitudinal studies that look at what are causes and what are effects, as well as understanding the genetic platform, I don't think we can sort out whether or not unemployment is the cause, or did drug use give rise to unemployment. The other thing that I think has not even begun to penetrate our collective conscience is the concept of epigenetics. Epigenetic changes that give rise to multi-generational drug use. There are preclinical studies in animals that show that if an animal is exposed to drugs during adolescence, and then they never see the drug again, and then they mate as adults, their children, their offspring, we can't call them children, their offspring, in fact, have a predisposition to liking drugs at higher rates, and their brains are different than the brains of animals whose parents were not exposed. And I don't know how far the research will get, whether or not it's applicable to humans, but I think that this is an area that requires some in-depth scrutiny going forward.
Leaves you all without questions. Or maybe there are enough questions on the table, it's hard to add any more. But Mike, we'll go to the center here. Yeah, thank you.
Thank you. Thanks, Alan. I wanted to get back to what you were talking about, medication-assisted treatment, and if you could expound a little more on the biological basis of the disease, the difference between addiction and dependence. Partly I asked the question because in working with some governors, I know there's been some frustration about the court systems and judges who sometimes view medication-assisted treatment as you're still an addict, you're still using a substance, you need to go to jail. You can only be going into therapy if you're off of treatment. And then also, I don't know, Professor Madras, the epigenetics is a fascinating area. I don't know if you've looked into epigenetic changes from chronic pain or untreated pain as well, the flip side of epigenetic changes from opioid use.
So that's a wonderful question. So our report does recommend that medications-assisted treatment be offered to prisoners, to parolees, to everyone, and judges have to back off and give rise to modern medicine instead of personal points of view.
Yeah, I realized when I asked my first question about consensus, there is, if you will, elite consensus, and then there's broad consensus, yes. And I fear that part of what you captured in terms of consensus was sort of an elite consensus. I don't have another word for it, but
it was evidence. Sorry, with all due respect. No, I think that we need to inject science into opinions. You know, there's so much misinformation about drugs in our communities, in our legislators, in our ballot initiatives that don't match the science. In this case, the science says that medications-assisted treatment, as my colleague so eloquently stated, reduces HIV/AIDS, reduces reversion to using heroin, keeps people in treatment, reduces a lot of the consequences of heroin and other types of illegally obtained drugs. And the reason is the biology is different. When you inject heroin, you get a surge, an absolute surge of I won't use dopamine, but dopamine is the common vernacular. You get a surge in the reward system. That surge and then the serenity and all that persists for quite a long time. With medications-assisted treatment, such as methadone, buprenorphine, you don't get the surge. The surge comes with heroin, IV, or insufflation, or smoking. With medications that are oral, you just get this Steven sense of peace. Your opioid receptors are not screaming for high doses, and that's what enables a person to have a relatively stable affect during that period of time. The antagonists like naltrexone block the receptors so that if you're tempted to use heroin, you don't feel it because the sites are occupied. It's like having a key in a door, and you try to use a fake key. That key's not going to work because there's already one in the door.
Let's get a question over here. It's been quiet on this side of the room.
Hi, thank you. My name's Naomi Seiler, and I teach health law and policy over at GW. And my question is regarding insurance status. And I know we're not talking tax policy, but I think it's hard not to talk about health policy a little more broadly. And with the consensus that there needs to be increased access to MAT, increased access to alternate modalities for pain treatment, there's an assumption that someone will be paying for that. But particularly some of the populations that Sir Deaton showed are most at risk are also most likely to be uninsured. So middle-aged men, poorer men, et cetera. So I first of all was curious, Sir Deaton, if your data included any information about insurance status with regard to deaths of despair, not necessarily as a causative factor, but just as whether there's even a route towards payment for these kinds of services for those populations. And then just if others had comments about what's going on with attempts to increase or decrease access to insurance for these populations.
Just quick factual, we don't know the insurance status. Most of the evidence you've seen there comes off the death certificate, so if it's not on the death certificate, we don't know. The one thing we haven't done as much on as we should is marital status, which I think is a huge cross-cutting thing here. So, yeah. I'm sure it's important. I should say, though, that pain treatment is almost as hard as addiction treatment. The reason that Anne and I got involved in this is she suffers very badly from lower back pain, and docs have no idea how to treat lower back pain for a very large number of patients. So you can see why that created a huge opening for drugs like this. She also, like me, throws up given opioids, so not even they work for her. But that's a real problem out there.
Rebecca.
I think just as to your question about the uninsured, I think that is a huge problem. I think, back to Representative Custer's comments, that kind of is a reason that we need to maintain these Medicaid expansions, include the on insurance on the exchanges, but there will still be a significant portion of the population of that's affected by this epidemic that are uninsured, and that's where a lot of these community level interventions, providing funds and block grants to states to be able to provide more naloxone, provide more medication-assisted treatment therapy, putting infrastructure into more housing, more unemployment assistance. Those sorts of things I think need to come into play, but that population is going to be harder to reach.
Towards the back, I'm going to have to. There you go.
City, Baltimore. So I have a pretty, and I've done that long enough to see the pendulum swing from providers not wanting to treat pain to perhaps over-treating pain. But obviously, as somebody who sees people who often have advanced illness and terminal illness, the population for whom these drugs were intended, and who in many cases do take them appropriately, if you can manage the potential for abuse from family members and neighbors, I'm concerned that the knee-jerk reaction, certainly among clinicians right now, is no one's going to get these drugs. And I'm just asking, how is that being factored into the national dialogue? Because they are appropriate for some people under, certainly hospice. Using these medications is generally very effective and appropriate. So how are we going to handle that to make sure that they continue to have access to these drugs?
That's a great question. So we know that opioids are useful at the end of life. We know that they're useful for cancer pain. You mentioned that there's still issues with addiction in some cases, particularly with cancer, and that is true. However, we also know that these drugs are not that effective long-term for chronic low back pain, for example, for migraine headache, for fibromyalgia, and yet we have inordinate prescribing for those disorders. So I think part of the issue is around making sure that the conversation always includes, acknowledging that at the end of life, opioids are appropriate, but also that they're not appropriate if you have a chronic long-term condition. One issue with prescribing and why it increased has to do with the fact that people treating patients at the end of life thought it might be a good idea to extend palliative care to others who had longer to live in chronic conditions. And that was partly based on bad information from Porter and Jick article and other articles that said addiction was rare. So I think the pendulum does still have to swing back to less prescribing, but it doesn't have to do so for all conditions.
I completely agree, but I think one of the unintended consequences of an overreaction with tamper-proof medications, with cutting down patients precipitously, was that there was no attempt to think through what will happen to patients who are precipitously removed from drugs. One of the questions that went unanswered, what is the difference between addiction and dependence? Dependence is becoming more and more of an obsolete term because it used to imply both addiction as well as physical dependence. And physical dependence can happen to every single person in this room on chronic opioids. If you're given them for a few days or a few weeks, you will go into withdrawal. Most of you will. And that has nothing to do with addiction. It's just that the body neuroadapts to the opioids, and you end up with cold sweats and nausea and what have you. But nobody considered, once you remove an individual, that they could go into withdrawal, and they were addicted, and they were going to go to heroin. They were going to go to the street because it's less expensive and you don't need a prescription. That kind of scenario is something that we addressed in the report as one of the unintended consequences as well, because medical education now has to include screening of patients for addiction and an alert system that says if the patient has developed an addiction to opioids, there has to be an algorithm on what to do about it, rather than just say, this is enough, there's no evidence for it, goodbye. That's a drastic step that was taken that has really caused some of the problem we see now.
Mark, in Britain, they've used heroin end of life forever, and it's never resulted in this problem. So I agree with what Bertha just said, which is incredibly important, that getting there is the hard place, but there is certainly a solution in which opiates are used at the end of life without generating the crisis we've got here. That doesn't help you get from here to there.
And just one last, I think that sort of to the different conditions, there is a lot of work we can still do, and the Commission commented upon this also on the acute prescribing side also. We have the CDC guidelines for chronic prescribing for chronic pain, but we know that a number of people do get addicted upon the exposure in an acute pain context. But opioids are quite effective for treating, post-surgical pain and things like that. So coming up with, and then we know people, if they get more than 5, more than 9, more than 30 days of a prescription, they're more likely to become long-term users. So I think doing some more work around what are the acute prescribing guidelines, and there are some places like there's an initiative in MOPEN in Michigan where they have come up with some of these prescribing guidelines, and maybe we want to ramp those up to a national level, but thinking about what are the recommended best practices for acute prescribing. Some states limit it to 5 or 7 days and things like that. But giving those prescriptions and then having the patient come back, and if they need additional pills, give them at that time instead of initially giving the 30-day prescription. So there are some other levers that we can use. It's not all about just either giving the drug or not giving the drug.
Right behind the person who just asked the question, out towards the window. There we go.
Hello, this is Ju-Young Cha. I'm Ju-Young Cha. I'm working in health policy for the federal government. When I actually think about the opioid crisis, I can't help but thinking about the pain management issue. So, as the person who just asked a question, there are people who actually need this kind of medication. But at the same time, pain is very personalized experience, and it's also both physical and psychological. And we have tons of evidence, scientific evidence nowadays, saying that pain test sensitivity and pain catastrophizing actually affects the usage of the opioids. And also, there are people who are prone to more depression. They're also prone to more addictions and utilizing the opioids. So it seems like if we really want to talk about the prevention, we probably need to talk about the more
just very quickly, in our commission report, one of our we have, by the way, 65 recommendations, which includes the interim report. One of them is that we do comprehensive mental health screening, as well as addiction screening, as well as physical screening of all patients, so that we can understand where along the spectrum they lie with regard to any one of these 3 converging issues that could give rise to pain as well as opioid prescribing as well as addiction?
That was a great question. I was just going to comment that the way that we've been thinking about pain is in terms of driving down numeric pain ratings with opioids. And that has led to building up of tolerance, dependence, addiction. And as you describe pain, it's really there's psychological and social elements to it as well. You may be out of a job, you may be having problems in your family life that are making the pain more apparent to you. And so once we can reconceptualize how we treat pain and to see it as an issue that extends beyond just a neurologic event, then we'll be able to address it in a better way and in a way that does not necessarily require opioids.
I'm going to interject a question, and then we'll take a couple more, and we'll be at the end of our time. I want to talk about leverage points for change. I mean, I'm just struck by how much we're hearing needs to happen. And those of us who've worked in healthcare know, and Bertha, you went into some detail about this, the translation of good ideas into overcoming all the resistance, both intentional and often unintentional, just because people are busy, is transition is very difficult, very slow. So this is a problem that we don't want to just sort of sit on and let it go fester. And the downward, this small downward turn in prescribing does seem like a good data point. But I'm interested in some other thoughts around leverage points. So you went quickly over the slide where you showed the separation of the addiction treatment system from the rest of the healthcare system. That seems like a potential leverage point because we're doing all kinds of things supposedly to change delivery of care in healthcare and hold health systems accountable for outcomes. And if we could sort of push this into the stream, that seems like a stream that might give us some more force behind us. Rebecca, you talked about the emergency declaration, the potential of federal authority to move things along. The Congresswoman spoke a lot about local action necessary. I want to move a little bit away from not that they aren't important, but sort of the questions of what we need to do to the how and where do we get some movement. What moves this agenda forward more quickly?
Well, the first thing is the federal government has full leverage over CMS, the Centers for Medicaid and Medicare, because they reimburse hundreds and hundreds of billions of dollars of health care in the country, and they're very linked to commercial insurers. And so what the leverage that we have, not we, but the federal government has, I'm a special government employee only until December the 1st, and then I'm back to private citizenship, is quite profound. And one of the things that we recommend is improving the quality of treatment with regard to reimbursements, improving the roadblocks to providing treatment as well as medications for treatment, and disincentivizing just sleight of hand approval for opioids. There's tremendous leverage at that level. The second issue that we have leverage in terms of the federal government is using pain as an assessment score for physicians, hospitals, and other healthcare organizations, which has been a primary pressure on physicians, because when patient pain assessment and patient satisfaction scores are scored in, there is a financial disincentive. There's a financial incentive to use opioids, because if a patient says, you didn't satisfy my pain by giving me opioids, that physician, that hospital can be financially penalized for not doing it. The federal government has leverage, tremendous leverage, in disincentivizing pain as and patient assessment with regard to those factors. There are many others. I won't hog the time, but there are many other leverages the federal government can use in terms of regulations that can be enormously helpful in beginning to dampen this.
One other place we haven't discussed too much, but some of the costs for some of these, some of it's reimbursement, but also the costs for some of these drugs are quite high. One that I think is very promising is probufene, which is an injectable buprenorphine. It lasts for 6 months, and it's less susceptible to diversion concerns. Really expensive, $5,000, I think, about per administration. So thinking about ways that the federal government can leverage some of its purchasing power and then negotiate on behalf of Medicaid to actually bring these drugs down, get them covered by insurance, and get them, in mainstream, more circulation, I think. Naltrexone also is quite expensive. So there are things, because the government is such a huge purchaser, that we could do to try to get those drugs down that don't rely on the private sector quite as much.
Okay, we have time for a few more questions. Alice?
I wanted to ask about, Alice Rivlin Brookings. I wanted to ask about the role of the drug industry and the pharmacy industry. It's been mentioned, Sir Angus mentioned, and others, but we always seem to just retreat and say we can't do anything about that because they're so politically powerful. And one of the previous questioners mentioned campaign finance reform, but that's a very general solution to a specific problem. So if you could do something to rein in the industry and the distribution, what would it be?
The FDA and the DEA could do enormous amounts. The DEA has done a lot. I mean, the 60-minute program that featured a bill that prevented them from going after rogue pharmacies because the clause said an immediate danger, and that's difficult to prove. That was only 2016. This problem has festered for 15 years. The FDA there are 50 applications now for opioids from the pharmaceutical industry. There are so many parameters that one can insist on that could make it prohibitive for approval. And I can think of 5 off the top of my head. The FDA could do a massive amount, which they were asleep at the wheel for a decade, and that's quite sad. Now I do think that they are committed to trying to alleviate this problem. But they're a key. They are a key. And there are many keys. As I said, there are 25 keys in this, but they are a federal regulatory key that's critical. And the DEA, their hands have to be untied from that bill that passed last year.
The FDA is funded by the pharmaceutical industry, right? I mean, that's one point. The 60-minute thing made it very clear as to how it wasn't the DEA stopping, it was Congress people who tried to stop them. And it's hard for me to believe that sort of investigative journalism, which in the past has done a lot of good. If you think of the muckraking in the 30s and, what happened 100 years ago, I mean, that can generate public pressure that makes it very hard for Congress to do those things. The shaming of the Sackler family, which seems to me long overdue, has managed to dissociate itself from Purdue Pharmaceutical and will never testify and has never appeared in public or even tried to admit that they have anything to do with it, while taking the family, by some accounts, has earned $13 billion over the past few years. And Purdue, up until last summer, had earned $32 billion from selling OxyContin. Those facts need to be much more publicly known, and the National Academy of Sciences, the Metropolitan Museum, and other institutions need to stop whitewashing families who are making money on the backs of people who are dying. And I think if that's out there much more publicly, then it will do a lot of good, because there'll be public demands to stop this sort of stuff. But, you know, Congressman Marino looks like he'll be reelected in the district he represents in Pennsylvania, even though his constituents are dying as a result of this thing that he engineered.
So one thing that I'm concerned about that no one's really talking about is that there are very close ties between these private claims databases and the pharmaceutical industry. So it was just mentioned in the New Yorker article that the Sackler family were co-founders of the IMS data system. And there are lots of other private claims databases that have consulting arrangements with pharmaceutical companies around opioids and other addictive drugs. So one issue, that helps them direct the conversation. So when they become stakeholders with research institutions like PCORI and NIH, that helps direct the conversation in ways that benefits the pharmaceutical industry. It's sort of a type of regulatory capture in a way. So they can talk about misusers and non-misusers, people who may be benefiting, and it sort of mucks things up, and we can't really get to a place where there's less prescribing and more appropriate prescribing. So I think something needs to be done along those lines in terms of regulation and making sure that we have access to, that researchers have access to these databases, and that we can feed that information back for quality measurement in the right way to physicians.
I also want to just make one, I completely agree the FDA could have done more, and it seems like they're moving in the right direction also through their REMS program. But I wanted to just mention the role for kind of litigation also here. You know, I'm sure many of you have heard about the increasing numbers of suits that are being brought by, you know, originally it was patients and then class actions, and now it's really governments, local, state, and even Trump says that we're going to have some federal suits coming our way and a number of settlements. And, you know, the settlement amounts are paltry and compared to the profits that these companies are making. But I do think there's a role for, you know, I think we could be looking along the lines of maybe potentially, you know, the big tobacco settlement here when all of these suits are aggregated. And that's a way for, you know, not captured, not, you know, disinterested consumers and their litigated lawyer representers to kind of tackle the problem from a different angle and actually hold, you know, many of these manufacturers, distributors, and even pharmacies accountable. You know, and it becomes hard when you can, through discovery, get some of these documents that show that a manufacturer, how could they not have known that they were shipping this amount of opioids to this locality, and that was, you know, way more than could possibly be medically used. And they're looking at these data. So that, you know, is another way that we can try to hold these actors accountable.
So I know there are a lot of questions still, but we are at time. We're going to have some closing remarks in a moment from Leonard Schaeffer, who, as Paul Ginsberg mentioned at the outset, is a trustee of the University of Southern California and of the Brookings Institution. But as he comes up, please join me in thanking Sir Angus Deaton, Bertha Madras, Rebecca Haffagee, and Jason Doctor for their comments.
I want to begin by thanking everyone who is here for taking the time to learn more about this very important issue. I am going to give some concluding remarks because my name is on the wall, not because I have anything to add, and I will be very brief, so do not worry. I'd also like to thank our excellent keynote speakers who helped us get a better understanding of this national crisis, and I want to thank all of our panelists. I thought that was a very interesting discussion. Now the paid political announcement. I'm a trustee both of USC and Brookings, and I want to note for the record that this conference was a perfect fit with the mission of the USC-Brookings Initiative, which is to use data and analysis to influence policy and to have impact in the real world. I hope that all of us are committed to encouraging policymakers to become familiar with the information that was presented today and to support programs that address opioid use. Especially now, it seems to me we should all reinforce the need for looking at the facts and developing solutions that are based on evidence. Facts are important and should inform public policy whenever they are relevant. Thank you, and we are adjourned.